Very much for joining us this morning. Just for the recording, I'll start again. Good morning, everyone. My name is Bim Akintade. I'm the founder for Health for Nigeria. Happy to have you here. Um, I played that video as an intro just to give us a very quick background of who we are and what we do. And I'll hand over to why we're truly here today. Health for Nigeria is a nonprofit organization registered both in Nigeria and here in the United States. And as that video showed, our mission is to increase access to health care for Nigerians, regardless of socioeconomic status. We have several interventions that we carry out. One includes primary healthcare interventions, health education and awareness, like we're doing today, where we identify subject matter experts across the world to provide information to not only Nigerians, but this is usually open to everyone. We're working on a healthcare leadership and development program, and we have multiple partnerships with different organizations. One of the things we're most proud of is the Nurses School program. That's our flagship program for Health for Nigeria. It's a program that partners with local public secondary or high schools. If we're afforded the space, within the campus, we renovate that space and we turn it into a clinic. And once it's turned into a clinic, we deploy a registered nurse to that space. It's usually in local rural communities. And for a lot of those communities, that individual then becomes an access to healthcare, not only for the students, the teachers, the staff, but the local community. We do 5 very important things with the Nurses School program. So we provide basic first aid for the students, the teachers, the staff, and the local community. We provide health education and healthcare promotion via a school health club. We originally started with COVID-19 education, and now it's expanded just to healthcare hygiene for students. We have community engagement initiatives, and our nurses actually visit students with chronic illnesses at home to educate their parents or caregivers. Health for Nigeria was launched in 2019, and we deployed our first school clinic in 2020. Well, I'm proud to say that by 2023, we've established 11 school clinics, and we're working on a 12th. So we've treated over 20,000 students for free and over 1,000 staff members, and we've executed over 15 community outreach programs. We've educated probably close to 30 to 40,000 students, and we've impacted several lives. So we're really proud of the work we're doing there. So without further ado, I would like to introduce our speaker today, who will be talking to us about kidney failure. This presentation is timely, as not only in Nigeria, but I believe across the world we're seeing more kidney failure, and just recognizing the challenges we face in Nigeria, we think this is a perfect time to provide some more information. So I'd like to introduce our speaker for today, Dr. Sharona Johnson. She's the System Administrator for Advanced Clinical Practice, which includes physician assistants, clinical pharmacist practitioners, and advanced practice registered nurses at ECU Health, that's East Carolina University Health. As a family nurse practitioner, she practices at East Carolina University Division of Nephrology and Hypertension. So she's the perfect person to talk to us, because I'm sure she'll touch on both. Dr. Johnson has worked in various healthcare organizations across the United States due to her husband's service with the United States Air Force. She's currently faculty at ECU College of Nursing. She's the owner of TMAR Consulting, LLC, which is Johnson's Healthcare Solutions, and a published author of Letters from My Grandmother, Wisdom of Ages. She's the past chair of the Center for Family Violence Prevention Board in Greenville, North Carolina. She serves on the Board of Visitors for the North Carolina Medical Board, Joint Subcommittee, North Carolina Board of Nursing, and Transforming Christian Ministries Board of Directors. She's the first Black alumni at ECU College of Nursing to offer an endowed scholarship for underrepresented students pursuing a nursing career, which is in memory of her mother, Rose Griffin. Dr. Johnson is presented nationally and obviously now internationally and published in several review journals. Some of her awards include North Carolina Great 100 Nurse, ECU Nursing Hall of Fame, and Excellence in End-Stage Renal Disease Care Award. Before she starts, I'd like to acknowledge members here from Health for Nigeria. We have members of our board here. We have representatives all across the world, both in Nigeria and the UK and North America. We thank you and appreciate your time. We also have members here from East Carolina University Health and the ECU College of Nursing. So thank you so much. And if you have questions, please type them in the chat box or hold them until the end of the presentation, and we'll have an opportunity for a Q&A. So I'll hand over to Dr. Johnson.
Thank you, Dr. Akintate. Hopefully you can hear me okay? Thumbs up? Great. So I just want to start by, like you said, acknowledgement. This is an honor that you've asked me to speak. I would like to acknowledge all the work you've done since you've been at ECU College of Nursing, and we're grateful to have you here. I also like to acknowledge and give gratitude to my chief of nephrology, Dr. Cynthia Cristiano, who is actually, not saying in a bad way, but my partner in crime. We both have a passion for patients with kidney disease, and I just love her example of taking care of patients, and also just recognition of Dr. Bowen, who is the chair of our department. So without them, none of this really could be possible. And we just have a great group that I work with. My colleagues are amazing. I'm going to advance the slides and just let me know if everything's working okay. And Ruth, thank you for your help with this as well.
Dr.
You're
Johnson,
welcome,
can you
Dr.
please
Johnson.
share your slides?
I'm sorry?
Can you share your screen?
Yeah, I thought they were being shared. Hold on. Okay, great. So we'll start with chronic kidney disease, and Dr. Akintate, I think you hit on some subjects that that I'm gonna talk about a little bit. That it's global. It's not one area, and I have some statistics and data to support that. But I just want to start out with see if I can advance these now. There we go. Still with me on the slides? Okay, great. All right. So we're going to I intend to introduce the kidneys and their function. So very basic starting out. So some of this may be ABC elementary for some of you, and then define chronic kidney disease, discuss risk factors and diagnostic criteria, an overview of treatment, and then just talk a little bit about the prevalence in the United States as well as in Nigeria. There we go. So I always start with the why. And so this is my mom, Rose Griffin, who we were just mentioning about the scholarship and her name for nursing. I'm actually partnered with another nursing colleague of mine whose mom also died from chronic disease. So my mom was diagnosed with end-stage renal disease. Not that she didn't have hypertension and she had diabetes, but the thing about end-stage renal disease or chronic kidney disease is that there's sometimes no symptoms until the end, and usually it's too late. So the kidneys are one of the organs that really don't regenerate. So it's not like you can have kidney disease end stage and say, oh, it'll get better or the kidneys will repair themselves. It doesn't work that way. So my passion comes from watching her journey through end-stage renal disease, dialysis, and eventually transplantation. And so as we talk about chronic kidney disease, I may share some correlations of what she went through with some of the things that Nigerians may experience or may not experience from what I've learned about some of the healthcare in Nigeria. So this is my why. So I'd like to start first with basics. And like I said, it could be ABCs for somebody, for some of you. But we have two kidneys. Most people do. Some people are born with one. And each kidney has about 1 million nephrons or filters. And these filters filter blood throughout our bodies about 40 times a day. And basically, the thing about kidney disease is that you can lose about up to 10%. I mean, you can lose 90% of these filtering units and have no symptoms. So a lot of times when patients present or people present with kidney disease and they're end stage and they're like, well, I had no idea I had it. They're right. They don't, because they don't have symptoms right away. And when the symptoms occur, it's usually in the late stages of kidney disease. And we'll talk about that a little bit. So the nephrons, the million or so nephrons that we have are our filtering units. And this is just a quick picture of what these nephrons look like. And I wanted to focus on the glomerula, which is the little red area in the center up here. So when you talk about different types of kidney disease, you know, we talk about hypertension and diabetes, and I will mention that. But also in Nigeria, it's one of the top one is glomerulonephritis, and that's usually inflammation or injury to the glomerula. And that can come from different disease processes. And I'll mention some of those a little later in the presentation. For the kidney itself, blood is filtered through the kidney. So unfiltered blood comes in, and then filtered blood leaves the kidney and goes back to the body. And then the ureter is where the urine exits to the bladder. So just some basic anatomy that, like I said, most of you probably already know. So what do the kidneys do? They filter blood and toxins throughout the body. They regulate our blood pressure, electrolytes, you know, like your potassium, your sodium. They help with those. They also really help with, you hear people, I know in the United States, some of the people in Eastern North Carolina where I live say low blood or anemia. So they produce a hormone, erythropoietin, that helps to make our red blood cells. So a lot of times, and I have stats on this for Nigeria also, when people present in late stages of kidney disease, they're very anemic. And a lot of times they need blood, or they need ESA agents or these agents to help build up their red blood cells because their kidneys are no longer producing the hormone that they need. The other thing that is produced or converted by the kidneys is vitamin D. So it's converted to an active form of vitamin D so that our body can use it. So the kidneys really do a lot. You can almost do a whole day on what the kidneys do for us. And so it's interesting, in 2002, the National Kidney Foundation came out with the Kidney Disease Outcome Quality Initiatives. And so this is 2023. So in 2002 is when this became a major recognized, kind of gave us guidelines on how we should treat kidney disease from stages 1 all the way to 5. Evidence-based guidelines, some were opinion-based, but you have kind of the Bible for kidney disease in front of you. And so it shifted the concept of chronic kidney disease from something that was uncommon and life-threatening to something that we can manage. And we had evidence-based guidelines to help us manage the stages of kidney disease in our patients. So to talk about what chronic kidney disease is, usually chronic kidney disease is kidney damage or a decrease in kidney function for greater than 3 months. So the thought is, why 3 months? Well, anything less than 3 months is thought about as acute kidney injury. So acute kidney injury is maybe you're out, you get dehydrated, the kidneys take kind of a little hit, and maybe your creatinine goes up a little bit, and we'll talk about those numbers. And you hydrate and you feel better. Or maybe you are sick and you get a process that causes your kidneys to, in some way, take a slight injury. But acute is something that we know you can recover from. It's not 3 months of kidney damage. It's something that we know you will recover. You probably will not need dialysis unless it's extreme. But chronic is if you've had kidney damage or a decrease in your filtering units or GFR for 3 months, you're going to be diagnosed with chronic kidney disease. And so that path or that cascade is started. And like I said, the time frame is usually the 3 months. So then when we talk about kidney damage, how do we know or distinguish what's what? Well, we have biopsies. We can biopsy kidneys in the United States. There's urinary markers like protein or albumin. And then for reduced kidney function, that's what we refer to as glomerular filtration rate. And sometimes we talk to our patients, or I talk to my patients, like it's a percentage. So I tell them a lot of times that we were born and blessed to have almost a little over 100% kidney function. And many of my patients, when I see them come in with about 7% kidney function, or I tell them your GFR is 7. And that's usually when we start dialysis on people in the United States. The majority of people start around 7 or 8. But based on our guidelines that I mentioned, the Kadoki guidelines that came out in I just got updated in 2012, most people based on insurance in the United States and other things can start with a percent kidney function of about 15% or less. And people with diabetes can start sometimes around 20% on dialysis. So when I talk about serum creatinine or glomerular filtration rate, there's an inverse relationship. So this slide kind of shows you as the creatinine rises, you see 1.5, 3.0, as that goes up, your GFR is going down. So one of the things I wanted to mention about this slide is that creatinine should be excreted through our urine or through our kidneys filter that. So it should be excreted through the body. You should not have high creatinine levels in your body. If you do, you pretty much know inversely that your glomerular filtration rate or your kidneys are not filtering as they should. The other thing I like about this slide is you can kind of see that if my creatinine is 1.5 or 3, my GFR pretty much has taken a huge hit. So the variation in range, as my creatinine goes up, sometimes your creatinine, even though the numbers don't seem huge and they're very minimum, your GFR could be almost like less than 50% or 40% by the time your creatinine starts to go up. So again, when you present to your doctor or to the healthcare provider, a lot of times patients have no idea that their percent kidney function has dropped so much. So what's important is timing. And that's what I've learned a little bit when we talk about Nigeria. It is actually getting in to see your primary care doctor or your healthcare provider or having treatment in a timely fashion, because I know that when we talk about people that have strokes and they say time is brain or heart, let's do something right away. Well, the same thing for kidneys. I mean, as soon as we can catch the kidneys in the early stages, we can slow the progression to end stage renal disease when somebody needs dialysis. So the sooner a patient can get diagnosed or seen, have the nurses in the community able to test these patients is very important, because we can delay the timing of somebody progressing to end stage or maybe stop the progression. So just a few facts about CKD. Early chronic kidney disease has no signs or symptoms. And like I said, most people will see the signs and symptoms in the late stages. What can we do? We can test for their creatinine, so we can draw blood and test their creatinine level. We can also get a urine albumin creatinine ratio, a protein creatinine ratio is what we call it. So what we're looking for is that, is there any protein or albumin in the urine? And this is an independent factor. So if you have protein or albumin in the urine, or your patient does, that's a good indication that there's some kidney disease going on. And so if we catch it early, we can go ahead and use medications to treat it, or go ahead and set up the patient based on those evidence-based guidelines to kind of slow the progression. And we'll talk about some causes of it in a few minutes. So there are 5 stages of kidney disease. So stage 1 is kidney damage, but you have normal function. So 90% to 100% kidney function. And then as you can see, the stages continue in severity or progression until stage 5, when the kidney function is less than 15%. The patient is probably starting to have symptoms, and that's when we have the conversation about dialysis or renal replacement options, dialysis, transplant, or some people choose not to do any type of replacement. And then this again just speaks to the albumin in your urine. The more albumin in the urine, the worse your kidney damage is. And so this is what they call a heat map. And of course, when you get from green to yellow to red, it shows again the severity. So just remember that protein in the urine, very quick to test for. I mean, that's just an independent factor that there's probably some kidney damage. So what are the risk factors? So I'm going to talk about in the United States a little bit, but like Dr. Akintotti said at the beginning, this is global. So diabetes, hypertension, heart disease, and heart disease can be from kidneys or heart disease can cause kidney damage. Family history, obesity, smoking, older age, and African Americans as well. And so what I want you to know about these risk factors is some are modifiable. So we can't change our age, we can't change our family history, but we can change, the weight, not smoking, control our high blood pressure, control our blood sugars. So some things are modifiable, some things that are in our control or within control to make a difference in how we slow the progression of kidney disease. So for the United States, 1 in 3 Americans are at risk for kidney disease. And the main causes in the United States are diabetes and hypertension. Now, like I said, for Nigeria, the third one I'd add on there is glomerulonephritis. And those are very common in Nigeria. Um, and so this is just a busy slide, but I like it because it talks about where do you start and where do you end. So screening for chronic kidney disease is important. And we're going to talk a little bit about when you go in the community or the nurses, some of the things that you may have access to, or some of the things you should notice when you're going out to those the people in the communities. So we want to reduce the risk of kidney disease. So we want to get the diagnosis early, and then once you get a diagnosis, you want to stage the kidney disease. Remember 1 through 5, and we want to try to slow the progression as much as we can. Basic. So if you can get a urine and screen your patient for protein, that's number one. And I think I've just mentioned that enough that we know that if there's protein in the urine, there's a problem. Once the kidney disease is diagnosed, again, we want to stage it. Is it stage 1? Is it stage 5? Where are we on this progression for this patient? And then we want to think about our interventions. So we want to control blood pressure. You want to control the diabetes. So keep the blood sugar or A1C within a range to stop the kidneys from progressing. Encourage weight loss, physical activity. If the patient smokes, you want to try to stop, give other options for smoking cessation. It's not always easy for patients to do this, but there are medications and different things that could help. Discuss the medications and supplements. And so one of the things I noticed in the literature when I was reading about Nigeria is that sometimes the glomerulonephritis or some of the kidney disease can be caused from herbal treatments or things that people in the community feel like may work or may make the kidneys better when they in fact make the kidneys worse. Medications that can be started for these patients are ACE inhibitors, or we call them ARBs. And what they do is they offer some renal protection for the patient. And some of the names you may hear are like losartan or lisinopril or those kind of names. SGLT2 inhibitors also have shown to show cardiac protection and some renal protection. And then mineral corticoids also help. And I know it's morning here in the United States and it's like about 2 p.m. in Nigeria. So I'm still in the mode of waking up. And then we want to monitor and treat the complications of CKD. And I have a whole slide that'll talk about some of the symptoms you'll see with your patients when you go out and are doing your exams in the community. So I mentioned earlier that the kidneys aren't able to produce the hormone that helps with anemia. So one of the things I read in some of the literature for Nigeria is that a lot of the patients present in the late stages. So when they present to the hospital or you see them in the community, they're probably already anemic. And so that does not set them up well for how they're feeling or being productive in society, because they're usually feeling very tired or not feeling very well or able to work and contribute to their families and stuff because of some of the anemia. Acid-base disorders, so like they may have high potassiums and their bicarbonate may be low. So there's different things and different medications we can supplement with to help for that. Another article or study that was done on nutrition in Nigeria, and I have a slide on that, shows that many times by the late stages when people in Nigeria present, they're very malnourished. And I can talk a little bit about that in my later slides about protein and how that can be tapered to help these patients. Potassium, again, can kill the patient if they don't get the care they need, because too high or too low is not good for our patients. And then there's some bone mineral metabolism things, calcium imbalance and phosphorus, intact PTH or parathyroid hormone, and then vitamin D, which I mentioned, we have to work on supplementing that as well. So this slide, and I believe you're going to have these slides, but this kind of shows you a little bit, and I like this because it gave you an idea of where in the body is being affected. So the renal affects the bones, and you can see the muscle weakness, the bone pains that the patients may experience. A lot of times when people present with late stages, we can listen to them around their heart, and you can tell if the sounds are muffled. Maybe there's some pericarditis, or maybe there's some fluid around their heart. Also lungs, you can hear rows, or you can see that they're having trouble breathing. A lot of times I ask my patient, how many pillows do you sleep with at night? Or do you get up at night and have to catch your breath? So this just gives you an idea of overall what you can see in your patients who are in the community that you're going out to see. So when the kidneys are no longer able to meet the body's need, remember, usually less than 15%, they're in what we call end-stage kidney disease. And then our options are dialysis or transplantation. So I'm going to speak from the United States, and then we'll shift to Nigeria. So dialysis doesn't make the kidneys better. I tell my patients kidneys work 24/7. They don't take a break. For dialysis in the United States, we do usually 3 treatments for about 4 hours every week. And then the dialysis itself removes the toxins, and dialysis in the United States can be done at home or in the dialysis unit. So there's 2 main types of dialysis, and one is hemo, which I call the blood dialysis, and the other one is peritoneal dialysis, which is done through the peritoneal cavity. And I have a little picture here. So hemodialysis, we try to have a access for the patient. So we want to remove the blood from the body. It goes through a filter we call the dialyzer, and then it's returned to the patient's body. The toxins are removed and disposed of, and usually, like I said, most patients are about 4 hours in the dialysis unit. When I talk about an access, we want our patients to have what we call a fistula, a graft, or a central line. So the number one push is to have a fistula. A fistula is where a surgeon has to take an artery and a vein and attach it to make an access. That's probably what we like the best for our patients. The second would be a graft. So many times, because of hypertension and diabetes, the vasculature is not there. So the veins are not as strong and the arteries are not. So a lot of times we have to use an artificial connection between the two. And that's where you see the white part of the graft going on. And it connects the vein to the artery. And we can use that for dialysis. The worst type is the central line or the tunneled catheter. It goes in under the skin, and the tip of it sits in the heart. And so there's a great chance for infection, and the mortality can be really high for patients who get infections with these tunneled catheter. The caveat to that for you to know is in Nigeria, this is the main type of access for patients. And it's because of just the resources, and also not having surgeons that are able to go ahead, and not having enough surgeons or accessibility for patients to get the graft and the fistula. And of course, as you know, the cost is also astronomical for people living in Nigeria. So many of the studies show that most of the Nigerians who undergo dialysis have the catheter, which is not what we recommend. In the United States, this is what a dialysis unit looks like. We have freestanding dialysis units, which are not part of our hospital. And again, what I'd like to just mention is, when I read, and I'd like your input as we get through this, in Nigeria, most of the people with who need dialysis actually have to go to the hospital to get it, and they have to pay for it. And I'll talk a little bit about adherence and what that looks for the community in Nigeria. So again, in the United States, we can do home hemo. So the blood dialysis could be done at home. And when I talked about my mom and her path with dialysis, she did the home hemo. She cannulated or stuck herself and was able to do this. And it's usually done about 5 days a week. Not, it depends on your body mass, but it could be 3 hours. You have more, you're more liberal with what you can eat, with what you can drink, and you can do it at your own time. You can get up at 2 a.m. in the morning, or you can do it at night or during the day. It's very convenient to do at home. You don't have to have a partner, but we recommend that you do just because you're connected to the machine at home. And so if something goes wrong, you can't always just detach from the machine right away. So it's good to have somebody in the house with you to help with this. The other type I mentioned is PD or peritoneal dialysis. It goes in your belly, and there's a PD catheter that is in your belly, and I have another picture next that'll show you what that looks like. And fluid is put into the peritoneal cavity, and it's drained out. This could be done manually, where you see the lady with it on a pole here, or it could be done at night with what we call a cycler. That machine that you see is called a cycler. It can be performed at home while the patient is sleeping. And then they wake up in the morning and they disconnect, and you can see what the PD catheter looks like because the gentleman's holding it in his hand. And so this is what a lot of the children in the United States do. Adults, we try to get them to do it if they feel comfortable right away with it. If there's no surgical reasons like any surgery or scarring in their bellies that would prohibit them from doing that. So we do try to push peritoneal dialysis as well. And then transplantation. This is the best form of renal replacement therapy. Preemptive means you know you have end-stage renal disease, you have a donor that wants to donate, and you can get a kidney before you go on dialysis. So that's preemptive. Living donor, and this is something that you should be very familiar with because this is common in Nigeria, is when a relative or somebody you know can donate a kidney. And then we also have deceased donors in the United States that we have patients who are on our transplant list and waiting for kidneys. The wait is usually about 5 years. So many times patients are on dialysis for about 4 or 5 years before they can get a renal transplant. And that depends on how well they are doing, and they have to go through a series of tests and exams before they can be on that transplant list. So I just talked about an introduction to the kidneys, very basic. Talked about chronic kidney disease, remember greater than 3 months, and then you're considered chronic kidney disease. Discuss some risk factors, diabetes, hypertension, glomerulonephritis, how you diagnose, make sure you're looking for the protein or albumin, as well as the serum creatinine and GFR are important. And then just overview of some treatments, control your blood sugar, control your hypertension, early access to care. So now we're just going to talk a little bit about prevalence. So in the United States, 1 in 7, 15% of United States and adults, 15% of adults are estimated to have chronic kidney disease. About 2 in 5 adults have severe chronic kidney disease and have no idea. I can tell you I had a patient yesterday who presented, and she said, well, my family doctor told me my kidneys were bad. And she had percent kidney function or GFR of 8. And so now the conversation is we need to talk about dialysis, which is a tough conversation to have when you first walk into a nephrology office. So in the United States, percentage of adults with CKD, what I wanted to point out here is that usually in this graph, you can see that mostly the 65 plus is where we have most of the adults with the chronic kidney disease in the United States. What I found for Nigeria is it's really the 30 to 40 to 50-year-olds. So a lot younger in the Nigerian population. And then overall consequences of CKD, increased hospitalizations, that was seen as well in Nigeria, cardiac events, also the rate of death from any cause. So your mortality rate can increase with this. So this slide is a little busy, but I like it because I just want to point out when you look at cardiovascular mortality with end-stage renal disease, um, up here is about a 34-year-old that maybe has no basic problems, just kind of a normal person. And then if you take this and compare it, this is, I'm sorry, a 34-year-old with end-stage renal disease is similar to an 85-year-old cardiovascular risk. So it shows you that even though you're young and you have end-stage renal disease, your mortality is synonymous, almost the same with somebody that's 85 years old who does not have kidney disease. So that is just how severe the chronic kidney disease is and how much it affects morbidity and mortality. So end-stage renal disease for America, about 600,000 Americans are on dialysis. 20% die within a year, and about 50% die within 5 years. And there's about 100,000 Americans waiting right now to receive a kidney transplant. The only other thing, I have two other things just to talk about, is that the executive order in 2019 again looked at kidney disease. So kidney disease is very well known in America, and we have also support financially to try to get help and have people get dialysis who need it. There are initiatives to push more for transplants, as well as to have more patients do home dialysis, which is more dialysis for them than 3 days a week in a center. So their outcomes are better. And like I said, our kidneys work 24/7. And so we just are trying to do the best we can to give our patients the best outcomes that they can have. And so globally, we talked about in 2017, the Global Burden of Disease Study, which looked at the global prevalence of chronic kidney disease, which was about 10%. And the majority of cases were in were in China and India. And then the only other thing I wanted to mention was chronic kidney disease resulted in 1.2 million deaths worldwide. So when I talk about prevalence and impact of disease, obviously Nigerian flag here, I just wanted to talk about what it looks like in Nigeria. And this is where you guys can probably weigh in more because you live there. So it's a financial burden. And what I was talking to Dr. Akintadi about yesterday, I was like, I cannot believe that patients have to pay for this out of their pocket. And so he goes, I was trying to tell you, is what he said. And so it's a financial burden because it's a cost to the family, it's a cost to the patient. And so many of the people who have end-stage renal disease or need dialysis, they kind of rational it for themselves. So they may go 1 day a week. Maybe I can afford one treatment, or maybe I can afford a couple treatments. So it's very sporadic and spread out because of the cost of it. And I have the cost a little later in the slides. It's not cheap. So I found a study that talked about a prevalence study or a population study of 8 communities in Nigeria. And they looked at patients, which was a cross-sectional study, who had end-stage renal disease. And 90% of those patients in that study with end-stage renal disease requiring dialysis, 90% of them were dead in 90 days. And that was the mortality on that, just because they could not get the care they needed. And that was one of the largest studies that was done in Nigeria over 8 communities. So end-stage renal disease accounts for 8% of all medical admissions in Nigeria and 42% of renal admissions. Like I said, it's the 3rd and 4th decade of life, where in the United States, it's usually 65 and above. The main causes that contribute are age, hypertension, obesity, diabetes. The medicines we talked about, herbal medicines that, because people can't get the treatment they need or don't have access to care, they think about what may work or what we can do, or maybe traditional remedies. The other thing that can affect patients are over-the-counter drugs, Motrin, Advil, Aleve, BC powders. Those things are not good for kidneys, and prolonged use of those can lead to kidney disease as well. And we think about over-the-counter, so you got to also think about other medicines that can affect. So a lot of times when patients come to our office, we say avoid nephrotoxic agents. And those are things like, we mentioned the over-the-counter, but some antibiotics are bad for kidneys. Contrast dyes are bad for kidneys. So you have to also think about what the patient and is on and look at their medication list as well. And then again, in Nigeria, few patients have renal replacement therapy. So again, in Nigeria, causes of CKD, and I included the studies for you when you have the slides if you want to go back and look at them. But you can see hypertension and diabetes were very common. In Nigeria as well. And the prevalence is about 8 to 10%. And this was a study that was hospital-based, and the people who came in had end-stage renal disease. So about 8 to 10% of hospital-based admissions were because of end-stage renal disease. And 1 out of every 10 people in the community has CKD. And so if you look at the population of Nigeria, about 17 million Nigerians will have a various stage of CKD, whether stage 1 or stage 5. So that's how many people right now probably are dealing with this problem. And again, I've already shared what the age looks like. So when I talked about nutrition earlier, many of the patients with chronic kidney disease present late. So when they present late, they're already anemic, they're malnourished. And one of the things that we try to do when we start patients in the United States is we want them in a good nutritional state. And so we talk to them around stage 4 to kind of cut back on protein a little bit, because the more protein that you take in, you're going to injure your kidneys more and you're going to progress faster. So we try to limit the protein to about 0.6 to 0.8 kilograms per day. Many people don't know that. And so as they're eating and not thinking about it, when they present, they can actually make their kidney progression faster if they're eating more protein in the late stages of kidney disease. The caveat to that is if you start dialysis and you're malnourished, your mortality rate goes up. So it's a fine balance. That's why having a nephrologist or access to care is very important in dealing with patients in these late stages. And then in Nigeria, treatment adherence there was a lot of articles published on this. The thing about treatment adherence was really hard for me to understand for many reasons, because it's really hard to adhere when you don't have the access, right? And so it said that prevalence of CKD was reported to range between 11.4% and 18% in communities studied in Nigeria. And so CKD has one of the highest pill burdens. And what I mean by that is some of the patients that come in my office are taking 20 pills or more. So there's a lot of cost to it. There's a pill burden, and people just don't want to take all those pills or don't understand the action or implications of all the medicines they need to take. And again, the monetary burden. How do they afford all the medications? So when there was an article also published on medication adherence, and again, I included the resource for you. So about 57% adhered and 43 were non-adherent. So the question you should ask is, why not? Why didn't they adhere? Here are some of the reasons. They said the medicine cost too much. There were too many pills to take. Some forgot because of families and other competing priorities. They were taking alternative drugs. They couldn't afford the pills, so they had other drugs that they thought would work, other herbal medicines. And then, there were a lot of women in this study, and they said, we're tired. We just are tired, and we just don't want to do it. And then the last part I just want to talk about is the renal replacement therapy. So there are like 4 centers in Nigeria that have renal transplantation. Outside of that, it's not available, and the patients have to travel there. And in order to get a transplant, you must have a living donor. So a lot of times in this study, the patient who needs a transplant would show up with brothers or uncles or sisters or family members that wanted to transplant. And then for dialysis, there's problems too, because there are not enough centers. The machines break down. There's not enough equipment. There's not enough trained staff. And a lot of the renal replacement therapy or dialysis in the urban areas. So what do you do about the people in the rural community that needs it? And then like Dr. Akintadia and I are talking about, there's no government funding. it's not supported. So again, the patients and their families have to bear this burden themselves. And so what about quality of hemodialysis? So what if you can get there? Well, still it's the economic burden. So the minimum wage in Nigeria is about 30,000, and you may help me. Is it Nara? Is that, yeah, okay. And so that's equivalent to $150 in the United States. So that's the minimum wage. And so the average cost of hemodialysis is about 40,000 Nara. And so that's about $96 in the United States. So think about this. If the minimum wage is that and dialysis is 10,000 more, what's going to be your decision? So that explains a lot about the mortality once somebody has end-stage renal disease, because they can't afford it and they exhaust their earnings and savings. So what do we do? So I told you what it looks like. I told you the worst part of it. So what do? We spread the word. There needs to be infrastructure. So there's a lot of information on Nigeria and chronic kidney disease. I mean, the research is out there. We need to educate healthcare workers, just like you're doing on this this presentation here. Public awareness. The more the community knows and understands about what they can do, and early diagnosis will help. Getting quality of care for patients. It starts with advocacy for the government and people who are in leadership to try to help with this. And what you're doing, going in the communities and providing care and education, it's essential. So we need more or Health for Nigeria type initiatives to get out in these rural communities. So this was a great article too. I included it because it gave a lot of recommendations. This article and the authors who were from Nigeria recommended increased awareness. The government needs to expand the health insurance. There needs to be money to support this. Healthcare workers need to advocate for the population, and I feel like you guys do that every day. Getting involved with religious institutions to help them, the clergy and other people, help patients to go in to get checked or help with transportation to get there. Continual education for medical providers. And then, of course, there needs to be upgrades to the hospitals and community centers and the healthcare centers that are accessible to the patients in Nigeria. So that pretty much wraps up, and I wanted to leave time for questions, and I think I did. I don't know how to say thank you in Nigeria, so I decided to put it up here. My email's here if you guys have questions as you're dealing with things. But I would love to have comments or questions about what you've seen. And like I said, I don't know everything, but I also have my chief of nephrology on here who can also answer questions if needed. So I'm going to yield it to Dr. Akintade or the group to ask questions.
Dr. Johnson, that was a fantastic presentation. Thank you for all the research you did. I feel compelled to maybe adopt you as an honorary Nigerian now because of all the research and all the information you've gathered. So no, thank you. I mean, this was wonderful. And before we go into comments, I just want to thank everyone else for being here. Obviously, this is one of the reasons why we do exactly what we're doing. And Health for Nigeria hasn't done it without support. There's been tremendous amount of support that's gone into this. I've seen some of our board members, Dr. Oluwa and me, Dr. Lupeju, they're here, and there's a question from them. But also we have some of our sponsors here. I mentioned the nursing clinics we have in 12 different states, the Nurses School Project. So I see Dr. Jalade, Dr. Tosin Olateju. So members from ECU College of Nursing are here. I appreciate your support being here. ECU Health, I saw Dr. Daphne Brewington, thank you for being here. And a large population of folks here that I want to give a shout out to from the Federal Government College Adwani Alumni Association. So these are folks who have really sponsored and supported Health for Nigeria from inception. So for friends or family who are here also, I appreciate your presence. So thank you for the wonderful presentation. And there are a couple of questions in the chat box. But before we do that, I just want to get some reactions, to some of the information we've heard and just for folks to give some additional perspective. Dr. Lua, I may see your hand up.
Oh, thanks, Dr. Akitade. Dr. Johnson, thank you so much. That was a terrific presentation. I'm sorry I was in and out. I'm also in clinic right now, but I was in and out, so I probably missed parts of your presentation. But I have first a comment and a question. The comment, and I'm sure you covered on that, is, we know what the precursors of CKD are. It's the chronic illnesses. It's diabetes, it's hypertension, it's indiscriminate use of nephrotoxic drugs and all of that. And I think you alluded to that at the end of your presentation, that I think the biggest opportunity is in health education. I mean, just, making sure people, for instance, know that, your blood pressure. I was talking to a group of folks the other day, and I said, for anyone over 45 or 50, I think having a blood pressure device at home is like having a thermometer. You should have one, and frequently, use that. So I think you alluded to that, but I think we can't say it enough, especially in resource constrained places like Nigeria. I mean, that's got to be the main thrust of our message. So thank you for highlighting that. And I wanted to just ask, are you aware of therapeutic apheresis, plasma exchange, and in the use in managing CKD? Are you aware? Because that's I mean, dialysis is not cheap, but are you aware? I'll just leave it at that. Of that happening? Do you have data? Do you have a sense of how much that is happening in Nigeria? And once again, I'll just say thank you so much for all, this terrific presentation. And we're really proud of Dr. Akitade's leadership, here at Health for Nigeria. I'm one of the advisory board members, and it's just been a delightful run. And we're excited about what the future is bringing for Health for Nigeria. So thanks again.
Thank you. So your comments were very, very timely. You're right about the nutrition, the education. I didn't mention it, but for patients in the community, it's a kind of a double-edged sword, because we say you need fresh fruit and vegetables and low salt diets, and to definitely control your blood sugar and have kind of discriminate taste with what you're eating. But the flip side of that is, if you don't have the resources and the money, and your family can only afford this or get this, I think it's a balance. And so that's a struggle even for low income or rural areas in Eastern North Carolina, where I live, when they can go to McDonald's and buy the dollar menu versus going into a store and spending a lot on fruits and vegetables. So you're right, the awareness is important. As far as apheresis, I didn't see a whole lot. Actually, I didn't see any journals that published that for Nigeria. The big things were, the transplantation. Of course, there was some recent research on the artificial kidney, which is not ready. And then just the cost of going in and the living donors, and that there's not cadaveric donors. Apheresis, as far as treatment for chronic kidney disease, I am not aware of the research. I know Dr. Cristiano's on. I'm not sure if she is, but I have not seen much research that supports any slowing of progression for that or anything like that, especially in Nigeria. And then I think it still would be cost prohibitive. But I saw that she just turned her camera on, but I don't know if there's anything in the United States or anything like that. Dr. Cristiano, have you apheresis?
Yes, can you hear me?
Yes.
Yeah, so I think that's a really good question. I do not know of any data with apheresis in Nigeria. We do use apheresis here in the United States, of course, to treat some forms of kidney disease with good success. But as far as just using apheresis blanket chronic kidney disease, not knowing the specific forms, I don't believe there is much data there. There was a review of apheresis techniques, I think it was last year, and I'll be happy to share that link with Dr. Johnson, and then she can share it with everyone. But I don't have any specific data with that in Nigeria. It is effective in some forms of CKD and transplantation in the United States.
Thank you.
All right, thank you. We have a couple questions in the chat, and if there are other questions or comments, you can please put them in the chat. The first one for you, Dr. Johnson, from Muiz Salam, is could dietary choices have effects on the prevalence of CKD in Nigeria?
Yes, and that's what a lot of the research and studies showed. It was actually the lack of access to some of the foods and things that some of the patients with CKD had, having low salt diets, eating fresh fruit and vegetables, exercise, all those things are things that are recommended. Staying away from herbal medicines that can be nephrotoxic. But again, I think some of the research shows that the studies said that the people could not afford the medications that were needed, so they looked for alternative sources. So definitely dietary choices are what we recommend for our patients. We actually have our patients see dietitians sometimes to help with some of the choices, just because of the diabetes and the blood glucose and the hypertension, because we want low salt diets as well.
All right, wonderful, thank you. There's a question about noticing high levels of protein in urine, and if that's indicative of kidney damage. And I know you talked a little bit about that earlier, so maybe this is an opportunity to provide some additional information.
Yes. So usually different. So an athlete who goes and works out really hard can have some protein in the urine, but usually it's less than 30 milligrams of protein. When you get up to greater than 300, or what we call nephrotic range syndrome, that just kind of increases the progression of your chronic kidney disease to end-stage renal disease. So protein actually in the urine, when you see it consistent like that in high numbers or high volumes, that's an independent factor. I mean, that's showing you right there that that is probably some damage to the kidney. And if it's not controlled with ACEs or ARBs or other medications, that you're probably going to progress pretty rapidly to another stage of kidney disease or end-stage renal disease.
All right, thank you very much. There's another question about criteria to look for in patients with chronic kidney disease to know if they're a good fit for transplant, and so just to provide some additional context, obviously there are some challenges with access to healthcare providers, and I'm assuming this question is just asking, when does an individual know that they're edging towards transplant, or being candidates for transplant in a place like Nigeria?
So and Dr. Cristiano, you could weigh in a little bit if I'm not saying this right, but I know in the United States, we usually start referring people to transplant around 20% or so kidney function. And that is to start the workup. For transplantation in Nigeria, having a deceased donor, and unless I'm wrong, from what I saw, was not an option. Living donors were what most of the patients presented to the Zenith, I think it was Zenith hospital or other hospitals that did transplantation to get workup. And so for criteria, they can go in and get worked up for kidney transplantation around probably CKD4 is when the workup starts. And then CKD5 is usually when transplantation occurs. But the family members also have to be screened and screened for cancer, diabetes, hypertension. They have to also make sure the person donating the kidney is in good shape, and the person receiving the kidney also usually is screened for cancers and heart disease, and making sure that they're able to undergo a major surgery. So there are criteria in the United States, and we have UNOS, which is a national organization, whereas in Nigeria, that is not in place right now. So yes, there are screening criteria for living transplants.
All right.
And the other part of that is once somebody's transplanted, it's not the end all be all, because they have to also take immunosuppressants or medicines for the remainder of their life.
All right, wonderful. There's another question in the chat. So Basaya, who is one of our volunteers, she's thanking you for your presentation and asking if there are infectious diseases that could lead to the onset of kidney disease, knowing this can help us prevent both infectious diseases and kidney disease at the same time, taking into account the limited resources.
Yeah, actually there are, and I'm trying to think off the top of my head. I know some aspects of, and I'm going to call on my, my phone a friend. Dr. C, are you still on? I know strep is a disease that can sometimes lead to kidney disease. And there are other diseases when we talked about glomerulonephritis that can affect it. I'm trying to think of all the infectious ones. Sepsis or those kind of things. I know that lupus, which is not an infection, but also can lead to kidney disease. There's what we call FSGS, which is a hereditary disease that can affect many Black Americans or people in Nigeria. That's hereditary as well for some. Dr. Cristiano, any other ones that come to mind? Or Dr.
Yes, I think there are several that can affect the kidneys. One common is HIV. We know HIV can have a direct effect on the kidneys. Also COVID-19. We've learned COVID-19 can affect the kidneys as well. Some other things, Sharana mentioned the strep, actually some staph infections as well. We can have post-infectious glomerulonephritis. Also things like parvo, syphilis, and really the list is extensive as to infectious disease processes that can either directly or indirectly affect the kidneys. So being able to recognize those diseases and actually implementing treatment early can have an effect on the kidneys as well. And I think I now see Dr. Boland's face, so he may have something to add with that answer.
Can you hear me, Cindy?
Yes, sir.
I've been in 2 meetings and now I'm in my car, so sorry. No, but I would sort of branch out with that question a little bit. Did you come across any data, Sharona, on the prevalence of APOL1 gene and its contribution to CKD in Nigeria?
So yes, there were quite a few studies that mentioned that, and just looking at the connection between just African Americans or Nigerians with that, and mostly from what I could tell in the literature, it was usually predominant in the males, from what I could tell, just picking up on it. But the APO1 gene is a gene that's been studied to link to CKD through genetics. And so that's the in-depth of what I know about it. I know Dr. Boland studies that a lot, but yes, there were connections there or correlations.
One thing that I may add, and I don't know if we lost Dr. Boland, but at least in the United States, as far as I know, most people with COVID-associated kidney disease also were positive for that gene. So I think there really are some effects that we know if someone has that genetic, makeup, as they're exposed to infections or other processes, that can definitely affect the kidney's response and whether or not they develop CKD.
Well, Cindy, I am still here, and I think many have questioned, is it the combination of the APOL1 gene with all the trappings of Western civilization that has magnified the impact of that gene? And that's why I was interested in the prevalence of CKD associated with APOL1 genes in Nigeria.
Mm-hmm.
All right, thank you very much. Dr. Olu, I know you have your hand up, but I want to ask Dr. Johnson a question, and I think this would hopefully put some additional emphasis on prevention. In Nigeria, just as you mentioned, lots of younger individuals have chronic kidney disease. And when it's diagnosed, they're notified that they need a kidney transplant. And we do a lot of fundraising for our friends and our college mates. And, you know, a lot of times when I see those fundraising initiatives, I'm concerned because I don't think that takes into account the post-transplantation care, cost, or awareness. So can you talk to us a little bit about, so you've gotten a couple of questions about transplantation, and my assumption is a lot of people think that's a one-stop shop cure. So can you talk to us about immunosuppressants? Can you talk to us about the resources necessary to keep transplanted kidneys healthy for a lifetime?
So so let me know the next quarter so we can talk about that on the series, because that's a whole lecture in itself. And I know Dr. Boland was on earlier, and that's what he does. But once a patient is transplanted, that is not, like I said, the end all be all. Immunosuppressants are needed to stop the body from rejecting the kidney. And these immunosuppressants are lifelong. And so, you know, and the problem also that the person who's transplanted has to encounter is they have to afford these medicines. They have to be very adherent to these medicines so that the kidney's not rejected. And also it puts them at risk a lot of times if they're not monitored for certain levels of these medicines for infections. And so, you know, most patients who are transplanted and adhere to their medicines overall can do very well. But I mean, it is not that you just get a kidney and everything goes back to normal. These meds they have to be accessible to the patient, and also they have to be affordable so that patients can stay on it. And we struggle with that a little bit in the United States. I think it's better because patients, I think, who are transplanted, Dr. C, you could weigh in again, I think could get their medicines covered for a certain period of time, and then it was up to them or the family to go and start affording the medicines. So we have seen some rejections following patients who could not afford it.
And thank you very much, Dr. Oluwayemi. Thank you for your patience.
Absolutely. Thank you, Dr. Akitade. So this is a question for Dr. Christian. You know, there's a lot of talk about SGLT2s, the Jardiances in CKD. My question is, so how soon should we be thinking about those? I mean, if I have a serum GFR of 58, should I put my patient on Jardiance?
That's a really good question. And I think the data is still emerging, but we are really excited about the outcomes of those studies with SGLT2 inhibitors. So we are expanding our use of SGLT2 inhibitors. First of all, we thought, well, maybe it's diabetics with proteinuria, then maybe people with heart failure. I will tell you, in our clinics here in the United States, we look for an excuse to start an SGLT2. Whether that be a heart failure diagnosis, whether it be chronic kidney disease. So we are really expanding that. So I think from what we've seen, that would be my advice, that we are starting them. Obviously, we are looking for things like any open wounds, any history of, you know, urinary tract infections and things like that. So we are vigilant with those things as we start. But we have found that it has been fairly well tolerated in most patients, and we are using them. So I would encourage to go ahead and start early if you think someone is a candidate for that medication. Here, we do typically go stepwise. I know some places recommend you starting 2 or 3 medicines at once, but at least here in our practice, we usually start with an ACE or an ARB, and then we stabilize the patient. Then we move to an SGLT2, and then at times then we may also move into a finerenone, also the mineralocortical receptor type medications. So we do go in a stepwise fashion, but we do recommend to start early. And you may also be aware that now, I believe it's Farxiga, is the SGLT2 that's even approved for use in dialysis patients. So we do not start people on these medicines when their eGFR is very low, but if they are on the medicine, there is some data that you can maintain that, and even it may be helpful for dialysis patients, even with heart failure.
Thank you.
Wonderful. Thank you so much, Dr. C, for jumping in with the assist. Uh, we have a few more questions, and I want to make sure folks have their questions answered. So do you have numbers to share for TDC placement, fistula creation, and transplant by any chance? Did you run into any of those numbers during your research?
I can send you the article that looked at it. The problem with numbers is that there's no database that collects this for Nigeria. So these were like population or community studies throughout Nigeria. The resounding factor, or the thing that was consistent, is that the tunnel dialysis catheters were predominant. And so I can send you what the article that had most of the research on that, but there is no national database that collects this information. And so it's very sporadic and very population or community based.
That's wonderful. And that's Dr. Bumi. He's a nephrologist. And I know he's putting a team together to come to Nigeria to, place devices to do dialysis. So I'm sure that question was very strategic. So a couple other questions. What lifestyle advice can you give to people who don't have CKD, so as to watch and be careful?
If possible, access to care, so regular checkups, so that this doesn't sneak up on them. Lifestyle modifications such as weight loss or maintaining a normal body weight, exercise, and then of course diets that are healthy and fruit and vegetables if possible, as well as low sodium diets, and controlling risk factors for CKD. No smoking, low alcohol or no alcohol, and then making sure that blood pressure, if you have blood pressure, medicines to take them, as well as making sure glucose control is important. So basically lifestyle modifications are essential.
Wonderful. There's another question, and I was thinking about this earlier also. So thank you for the wonderful presentation. How do you handle a situation where a patient who has undergone a kidney transplant still has some form of CKD? And I know we see that, even with a transplant, certain patients may still need some form of dialysis early on.
And so my clinics are advanced CKD mostly, and I can speak to this, but I'm not an expert on it. So I don't know if Dr. Bolin or Dr. C want to take a hit at this one.
I know Dr. Bolin is our transplanter, but I'm happy to jump in here also. We do know patients that have gotten a transplant often do not return to a normal EGFR. At that point, it's kind of important to know the cause of their kidney disease to begin with, so we can certainly watch for recurrence of that disease. Then we would also treat them typically like any other CKD patient, making sure we're watching blood pressure, diabetes control, looking for protein in the urine. And many of the medicines that we use to control or slow the progression of CKD, we also use that in our transplant patients. We do recommend, that the transplanter certainly be involved in the care if possible. But we really treat them like other patients, with the caveat of knowing they are more at risk for infections, watching for side effects and interactions of medication, since they are on immunosuppressive drugs.
Oh, wonderful.
And we do have patients who have totally failed transplants and have to sometimes go back on dialysis, and also we can relist our patients for transplant if they're able to get another transplant as well.
All right, wonderful. So Dr. Lupiges, thanks you very much, and hopes your presentation would be a catalyst, for health promotion and disease prevention. And Dr. Oluwatosin is asking that we do a follow-up lecture, on kidney donation for donors and for transplant care, which I agree with you, Dr. Johnson. That's like a whole nother presentation. Let me take this time once again to thank you so much, Dr. Johnson. I know this was kind of short notice, but during our conversation, you were very excited, very energized, and we truly appreciate all the preparation that went into your presentation. Dr.
It was eye-opening for me. And again, I can tell you why Dr. Cristiano was my mom's nephrologist, because she definitely has a passion for this as well.
Trust me, it showed through your presentation. Thank you, Dr. Cristiano, for your presence and support. And also Dr. Boland, thank you so much. Super happy to see you here. Thank you once again, everyone, for your presence. We usually record these and we make them available on our YouTube channel, which is another way to, get it out there so others can see it. So we'll share that information the same way we shared this. So thank you once again, everyone. And enjoy the rest of your day. Thank you.
Thank you.